Hi, it's Julie Jones. We're going to talk about the electronic health records. So, I don't know if you remember the days, but in the old days, there used to be an old chart room, and the provider would request a patient's medical record, and they would go down to the chart room and pick it out from a bunch of boxes. So, I would say gone with those days, but still some hospitals do have that. And sometimes there's no getting away from having some storage of electronic health record system. I mean, just a regular health system, paper charts. So when we're looking at what the difference is between the electronic health record system versus the electronic medical records. So if you look at electronic medical records, it's just the paper chart from the provider's office or just the hospital. When we're talking about the electronic health record, it's all encompassing, but it's not just only the provider's office that has that paper chart, but also the hospital and putting those together. Some of the components of the EHR when we're looking at that could be it may have demographics, immunizations, test results, some allergies, the patient's insurance information, history, whether it's their past medical history or old notes, medications, clinical documentation, and also problem list. When we look at EHR adoption, we want to make sure that you examine the knowledge based systems that are currently in place and how they support current operations from the perspective of the provider, payer, and consumer. When we look at electronic health record system adoption, we're looking at whether we also want to use computerized provider order entry or CPOE, the electronic medical administration record or the EMAR. Here we just call it the MAR. Barcode med administration, that means scanning the patient and scanning the medication, and that administration goes right into the electronic health record system. The electronic prescribing or e-prescribe, and currently Vermont is the last state to finally adopt e-prescribing of controlled substances. So that just recently went into effect. Also looking at clinical documentation, so whether it's the nurses or provider notes or it's the flow sheet documentation, and any ancillary systems like the laboratory or imaging systems. You also want to identify the key stakeholders in electronic health record adoption. So it could be the consumers or the patients, nurses, providers, organizations like the VNA or hospice, insurance companies, and state and national governments. When we're looking at the benefits with cost, it helps to reduce transcription. So transcribing of notes is less used, so that reduces the amount of cost. um, Chart pool and storage is reduced, and then there's more accurate reimbursement, so there's a cost savings with that. So access, you no longer have to search for the chart. Also, providers and nurses can access the chart at the same time. Providers, if they're at home and get called in the middle of the night, they can access the chart and review the information in there. Quality helps to decrease transcription errors, helps provide some basis of decision support, and there's sometimes an automatic safety check like ordering a med, and a patient might be allergic to that type of medication. Some of the issues that have been identified with EHR adoption is, of course, the cost, because it's very expensive to um, have the whole of implementation of it. Issues with ownership, who owns it. If you have a multi um, provider or multi institution on, so who exactly owns it. Making sure that there's integrity with the data, that maintains, there's issues with privacy and confidentiality and making sure that that information is safe. Standards that go into it, whether it's quality or government, and also organization culture associated with it. So, the next thing I'm going to talk about is implementing information systems. So, I want to talk about implementation versus upgrades. So when you're implementing, you begin to make use of a new project. This only happens once. It's usually more costly because it's over a long period of time and it's a brand new system that you've never implemented before versus an upgrade where you're just going to the next version of that product. So you already own that product. This can happen multiple times a year, it can happen monthly, or it can happen yearly, and also you need a lot less resources for an upgrade. Some of the reasons to implement, we talked about the American Recovery and Reinvestment Act, with the setting up initiative for reimbursement regarding meaningful use, or the transition from ICD 9 to ICD 10. It also improves safety, quality, satisfaction, access of patient information. Some of the barriers to implementation is getting started and setting a timetable, buy-ins from staff, having to rely on steering committees, not getting enough training, like identifying computer proficiency among team members, physicians being difficult, or even nurses or any other users of the system, making sure that you involve them in the selection process and throughout the project, uh, and implementation horror stories, making sure that you have a detailed project plan and how to support implementation. When we evaluate vendors, we want to look at the product, ask other hospital offices that use that product, looking at the cost of the product. There are several vendor assessment tools that you can use to evaluate vendors, assess what your institution needs, or selecting a vendor, making sure that you schedule site visits, whether it's to that vendor or other hospital or institutions that use that um, product, or and the ability to integrate with other products. So if you develop a EHR and you want to make sure that if you already have a lab system or imaging system, that it integrates well with one another. So here are some of the type of vendors: Epic, Cerner, McKesson, Meditech, or Siemens, and Allscripts. These are all types of either electronic health record system, but also different systems like radiology and imaging. You also need to identify key stakeholders. Some of these could be the chief medical officer, having a physician champion, a nurse champion, project manager, a CEO, and I'm sure there's many others. It just depends on the project that you're implementing for your EHR or IT software adoption. Making sure that you have the right implementation team is key. So making sure that you have trainers, testers. So when you build in the system, making sure that you have enough testers in there. Ancillary team members, whether it's laboratory or imaging or whatever the ancillary systems are. Subject matter experts, EHR builders, nurses, physicians, and others depending on the product. When we look at any kind of development life cycle when implementing any kind of system, you want to make sure that you have all these key components to the life cycle so that your implementation and adoption is successful. So, analyzing, planning, designing, testing, implementing, maintaining, involving, and then, of course, returning to analyze and making sure what you put in is sufficient for your organization. So I'll go into these a little bit of a detail. So under planning and analysis, making sure that you have a foundation, that you've identified what the problem that you're trying to solve. ensuring that the key stakeholders are involved, that you review any current and future state workflow, and that you have the key components identified of why you're implementing and what is necessary to build in the system. Then when you go into making sure that you design and that the system is usable, you want to make sure that the end users will integrate with the new system, making sure that they have a say in the design of the system. Uh, Consistency, making sure that the save button is in the same place on each screen. For forgiveness and feedback, making sure that there's a warning message on how to fix an issue. You want to also minimize cognitive load, making sure that there's a reduced number of clicks. You don't want to be able to finish a workflow with 100 clicks, because otherwise there's a lot less adoption of that and people won't be following the correct workflow. And also that it's simple to use, that the screens are not too busy to look at, and they're uncluttered. So testing, it's important as far as adoption, is that you have testing of any system. You don't want to have any gotcha when you go live. So unit testing, this is when a builder is testing their own code. Functional testing is when you develop a script with a set of instructions, like placing an order for a medication which gets administered by the nurse and then documented on the MAR. Integration testing is incorporating several systems together, like a physician ordering a lab, which goes to the lab system and then gets resulted back to the EHR. And then user acceptance testing, making sure that whoever is going to use the system, test the system out in the current workflow and make sure that it works for them. And then training, making sure that you have the right training. If it's just if it's complex, you may want to do classroom training, but if it's less complex, you could do it in a video or a tip sheet. Implementation, making sure that you have a date to go live, any items that are needed that day, and a list of key items that either need to be moved into the system or turned on. Making sure that you support that end user that's on the floor using that new system, and then make sure there's a way of tracking any issues that should arrive. And then as part of maintenance and evaluation of the system is making sure that you have a way for end users to request improvements or redesign, that these requests are prioritized based on one is how long it will take, and also if it's associated with any government policies or quality improvement projects. Also, that this is based on evidence-based information, that the adoption and the design is whatever is put into the system is effective, and then also being able to review any data. Some of the risk factors associated with it could be some scope creep, where initial resources have a budget for, or for when more enhancements you want to make to the system than originally designed. This happens a lot. So you go in to do just a basic flow sheet redesign, and then the end user thinks, well, if we're going to redesign the flow sheet, then we need to redesign our order sets to make sure that whatever is done in the order set gets fulfilled by the nurse. So it's more than what was originally designed. Other risk factors includes financial resources, and then also software issues. And that's it for electronic health record system.